Hi, this is E. David Crawford, Editor-in-Chief, Grand Rounds in Urology. We are going to have Dr. Laurence Klotz, who is Chief of Urology at Sunnybrook Health Sciences Center and Professor of Surgery at the University of Toronto. He's also Chairman of the World Uro-Oncology Federation. Spend some time with us and give us 3 presentations in our Platinum Lecture series. Platinum Lectures, as you well know, are lectures that we hear and we think, wow, these are some of the best talks we've heard in the last 6 months. And recently, Dr. Klotz gave one, and I've asked him to come up with a Klotz trilogy, which is going to break this talk down, which covers active surveillance and also micro-ultrasound markers and a few other things, into 3 talks, about 10 to 12 minutes each. And we will have these in Grand Rounds in Urology. So Dr. Klotz, thanks so much for taking time from your busy schedule to share with the audience these presentations, and I know they're going to be well received.
Thanks, David, for that nice introduction. This talk is going to be an overview of the active surveillance story, a little bit about the trajectory over the last 20 years, the learnings from the studies of the molecular genetics of Gleason pattern 3 compared to higher grade cancer, and then a summary of what the clinical experience is and how we are managing patients on surveillance today. Welcome to part 2 of the active surveillance trilogy. And the focus of this talk will be on the role and also on the limitations of imaging and biomarkers in managing patients with favorable risk prostate cancer. So this is a kind of prototypical patient who was originally diagnosed with a single positive core of Gleason 3+3. And in the previous era, he would have had a confirmatory biopsy. Today, he goes on to have an MRI. You might be able to spot that lesion if you're astute in the anterior part of his prostate. The likelihood of hitting that with a systematic biopsy would be, I think, most unlikely. Now he goes on to get a targeted biopsy of that lesion, which showed Gleason 4+3. And you can see the whole mount section, which shows a microfocus of 3+3 in the left peripheral zone, which is basically irrelevant, and a large 4+3 cancer, which was actually about twice the size of the lesion seen on MRI. That really was the life-threatening cancer for this patient. So this is, of course, just one case, but I think it just emphasizes the potential value of MRI in improving the outcome of men on surveillance. So first, a brief discussion about MRI and how well it performs at identifying significant cancer. Because really the question we're asking in the surveillance population is, does this patient have something worse that is a life-threatening cancer for the patient? And what do we need to do to identify it? So I think the first thing we've learned over the last 5 years or so is that MRI does miss significant cancers in a considerable proportion of patients. Although, of course, it also identifies a lot of patients who would have been missed previously. This is a kind of overview of about 15 individual studies published a year or 2 ago. And I just want to emphasize, this is in the biopsy naive group of patients. The light bar is the likelihood of grade group 2 or higher with systematic biopsies in each one of these studies. The middle bar is targeted. The darker bar on the left is combined. And the overwhelming message of all these studies together is that there is an incremental diagnosis of significant cancer with combining systematic and targeted biopsies compared to targeted biopsies alone in every single study. And on average, this works out to about 15% of cases. This is a study from UCLA, Rob Reiter's group. They have been a leader in this area, and this compared the results of whole mount section of intermediate and high risk patients having a radical prostatectomy to their preoperative MR imaging. And you can see, particularly the bottom right, the patients with multifocal cancers who had cancers less than a centimeter. Around 75% of these were missed on MRI. It's really pretty shocking. And overall, in their series, and they are clearly a center of excellence, MRI missed 40% of grade group 2 cancers, about a quarter of grade group 3. So again, the message is pretty clear that while it is much better than no imaging for finding cancer, it misses plenty of them. This likelihood of missing cancer is a function of the underlying risk. This is what you could call the Bayesian concept. If the patient is a low-risk patient, so this might be someone with a single positive core of grade group 1 who has no racial or familial predispositions to worse cancer, the NPV of the MRI is around 90%, but a higher risk patient with a higher PSA density and other factors, it's only around 67%. So this is really a dramatic difference. And what it means is you need to risk stratify in terms of evaluating the reliability of MRI. And this is some other recent data. This is just published in the New England Journal very recently from Peter Pinto's group, patients who had elevated PSA with MRI and targeted and blinded systematic biopsies. Somewhere around 10 to 15% of significant cancer missed by targeted biopsy only. And again, this comes from one of the top groups in the world. And this data from the same study address the issue of the upgrading rate. So, and I alluded to this in the previous talk, with combined systematic and targeted biopsy, you still have patients with higher grade cancer found on radical prostatectomy missed on those combined biopsies, but the rate has dropped quite dramatically from around, say, 30 to 40% to 14% in their series. And I think this makes the confidence that what one can have in monitoring patients with low-grade cancer much more robust. I just want to show this perhaps some of the worst data that anyone has ever reported on the performance of MRI. And it's my data, or at least the data from our Canadian study, which I led. It was definitely a group effort. I don't mean to take all the credit. But this is called the ASSIST study, where we took about 275 men on active surveillance coming up to their confirmatory biopsy and randomized them between systematic biopsy and systematic with targeted MRI and targeted biopsy. And the striking thing about the initial data in this study was that the targeted biopsy did not increase the rate of finding significant cancer at all. And this is the positive predictive value for significant cancer for each MRI score. And you can see, for example, PIRADS 5, a third of the patients were upgraded to higher grade cancer with targeted biopsy. This compares very unfavorably to the precision study, the study in undiagnosed men. So it's a different population, but likely the risk of finding high-grade cancer in a group of undiagnosed men is about the same as doing a confirmatory biopsy in men on surveillance. It was 83 versus 33%, 60% for PIRADS 4 versus 24%. So there is clearly an issue of generalizability. Now, in retrospect, we have very good evidence that what we did was demonstrate a serious learning curve with the fusion targeted biopsy technique we were using in this study. But again, just to support the limitations of MRI, this was a recent study from Memorial Sloan Kettering of men with serial MRI on surveillance at baseline in year 3 with biopsies at year 3. And I think the disappointing thing was that the MRI did not correlate very well with the risk of upgrading on those 3-year biopsies. So fully about a third of men with a stable MRI were upgraded on the 3-year systematic and targeted biopsy. Even the men whose MRI improved, normalized, the lesion disappeared, decrease in MRI score, 19% were upgraded on repeat biopsy. So the message is use MRI, but don't rely on it 100%. Now, what can we do to augment the MRI? And this is where I think this high resolution micro-ultrasound looks very appealing. This is a new technology developed over the last 5 years ago that became commercially available about 2 years ago. It looks like a regular ultrasound machine, but rather than 6 to 9 megahertz and 200 micron resolution, this has 29 megahertz and 70 micron resolution. So the difference this makes is very substantial because 70 microns is the diameter of a prostatic duct. And what it means is that alterations in ductal anatomy, which are not apparent on regular ultrasound unless the patient really has a very large, tightly packed cancer, you don't see subtle alterations in ductal anatomy as you do with this technology. And this is exactly the same principle as restricted diffusion with MRI. It looks like a regular ultrasound. The cost is comparable to a high-end ultrasound unit. We have evidence that these patterns of alteration of ductal anatomy can be learned quite quickly, particularly for clinicians who are used to reading ultrasounds. And this Primus protocol or Primus scoring system has been developed. Clearly, the idea is to echo PIRADS, and it goes from 1 to 5 in the normal patient. And this is mainly the peripheral zone we're looking at. You get what's called a Swiss cheese pattern, which is a very symmetrical pattern. Each one of these little white dots is a prostatic duct. And as you get alterations in the ductal anatomy, you start to see these patterns which are easily recognizable, bright echoes, smudging, modeling. This is called the cauliflower appearance. You get alterations in echogenicity, and this does correlate with grade. And this just gives you an example. So here's a patient with an apical peripheral zone lesion. And with MRI, you would probably see this. The patient would have the fusion targeting. And at each one of those steps, there's the risk of error, as we learned with the ASSIST trial. Whereas here you see the lesion, you line it up, the needle goes through it. You can be very confident that you have successfully targeted that lesion. And here is our preliminary data. Now, the literature on this micro-ultrasound is increasing rapidly just within the last year or so. This is from a publication that I did, published in the CUAJ a couple of months ago, which was really the initial experience from a group of centers from around the world. It does incorporate the learning curve, but you can see this is patients who had an MRI and then an ultrasound and a targeted biopsy, that the sensitivity, this is the sensitivity, was actually somewhat superior to the MRI. The specificity down here was about the same. Now, there's many caveats with this data. Some of the centers were blinded to the MRI, but not all. That really makes a difference. It was a registry. It was not a prospective randomized trial in any way, shape, or form, but still it's quite encouraging. And these are the metrics where the sensitivity and specificity you can see of ultrasound versus MRI are quite comparable, similarly with the positive and negative predictive value. And this is a study that just came out a few months ago where from an Italian center in Milan, Lugazzani, where they were meticulously blinded to the MRI when they did the ultrasound, but this actually does validate the registry data that I just showed with, this is for each PIRADS and Primus score, the positive predictive value. Primus 5 versus PIRADS-5, you can see it all looks really quite comparable to MRI. And of course, it's a much cheaper, in some ways, a more readily available technology, doesn't require contrast, and so on. The caveats from this data, this represents about 1,700 patients compared to tens of thousands of patients, many of whom reported in prospective randomized trials for MRI. There's still some uncertainty about what the real specificity and positive predictive value are. This tends to have a longer learning curve than the ability to recognize abnormalities. The specificity requires the clinician to be able to say, actually, that looks slightly abnormal, but it's not likely to be a cancer. It takes more confidence and time. So that's the MRI story, and clearly this is evolving. Just some brief comments about biomarkers in surveillance. This is a summary of the commercially available biomarkers for finding significant prostate cancer. They're in blood, urine, and tissue. I think people are familiar with these. They vary in terms of cost, the area under the curve for significant cancer, bearing in mind that essentially none of these have been compared head to head. So this data all comes from the individual publications reporting on these individual biomarkers, but the area under the curve for significant cancer, somewhere around 0.75 to 0.9. Select at the moment has the highest area under the curve, but there are some competitors that are rapidly catching up. Cost varies from about $500 for the less expensive liquid biomarkers to $3,000 to $4,000 for the tissue-based biomarkers, which involve microdissection and are considerably more labor intensive. So first of all, a comment about the tissue biomarkers. You know, there's clearly value if you have a patient you're considering for surveillance, and there is some concern about whether that patient, a major concern about whether they have a higher grade cancer. So of course, the sweet spot is the patient with 3+4 who's considering surveillance, and does he have much more aggressive cancer than you think? And there's no question these tissue-based biomarkers have value in identifying patients who are at high risk, but they also have limitations, and the limitation relates to the genomic heterogeneity of prostate cancer, particularly multifocal prostate cancer. This is one Swedish series that took a group of 41 patients, did microdissection. They all had multifocality. And what you see here, the brown are the common mutations, the gray is the unique mutations. 95% of the mutations seen in these cancers were unique to that microdissected cancer and not shared by the other cancers in that prostate. This is some more, even more recent data, and it's the same story. And the title is Interfocal Heterogeneity Challenges the Clinical Usefulness of Molecular Classification of Primary Prostate Cancer. And basically, each one of these little blue bars is a different cancer. And what this shows is the likelihood of all the mutations being shared or being from separate molecular classifications or using the TCGA classification unassignable. And basically what you see is a whole lot of heterogeneity. These are the homogeneous ones. These in the light gray and the white are the heterogeneous ones. It's the rule, not the exception. So you have a Gleason 6 cancer, you do the Prolaris or Oncotype or Promark assays, and it tells you there's a risk of higher grade cancer, but given the degree of heterogeneity that we know exists, it's not 100% reliable. And this is one more study from the Canary cohort led by Dan Lin that looked at the incremental value of the Oncotype DX assay in men on surveillance, 432 men, about 40% upgrading, no association between the GPS score and upgrading. Adding the GPS score to PSA density and diagnostic grade grouping did not improve the stratification for adverse pathology. So this is pretty sobering. I think these biomarkers do have a role, but it's limited, and it's really mainly in the patient who is at the margin, the 3+4 who you want to follow with surveillance, and you want some further confirmation of safety. In contrast to the tissue biomarkers, there's clearly an emerging role for germline testing, particularly for BRCA and the other DNA repair defect related genes. The concept here is that in the sporadic tumors on the bottom, you have a slow acquisition of mutational events over, say, a 10 to 15 year period. You start with loss of P53 and some other tumor suppressor genes, genomic instability, and so on. You end up after a long time with worse cancer. Whereas in the BRCA2 situation, this all occurs right at the start, explosive accumulation of mutational events after the initial inception of cancer. And that is the key concept about the impact of DNA repair defect on cancer aggressivity, that everything happens much more quickly. So if you're contemplating a surveillance strategy, this is not a good basis to go forward. Just a recent publication that looked at the cancer spectrum. Obviously, these patients can get other cancers besides prostate. But just to show that with BRCA2 in particular, prostate and breast are kind of the major players. In patients who have two cancer diagnoses, breast and prostate, relatively common. Prostate cancer and cancer other than breast and prostate also occurs, and even a proportion of patients have 3 or more cancers. So the finding of BRCA2 has major implications for patient screening for other cancers, as well as for his family. We have so far only one series that I know of that looks at men on surveillance with DNA repair defect germline abnormalities. And this is from Hopkins. There were only 26 men with germline mutations, but the signal's pretty clear. Here's the BRCA2, and you can see that by 10 years, about 80% of these BRCA2 patients on surveillance had been upgraded to higher grade cancer. I think the real figure is 100%. They just missed the other 20. With BRCA1 and 2, same phenomenon, not quite as severe. Same story with upgrading to grade group 3 or higher. So the message is pretty clear that these patients are at risk and probably should not be managed on surveillance at all, unless they're quite elderly. This whole field is just exploding. I really like the color assay. It's widely available. It's not very expensive, as inexpensive as $100 for the BRCA only test, $250 for the hereditary cancer test. Amazing value for the information this provides. And when you find a patient who has it, then you can encourage him to get his children tested and so on. And the other part of this is if they have a family history and the test is negative, it's very reassuring. This skepticism about the role of the biomarkers is shared by others. This is a recent ASCO guideline that Scott Egener led, the recommendation that these may be offered in situations which the assay result is likely to affect management, but not widely recommended routinely, and I agree with that. There's more biomarkers coming, and I think you can imagine a scenario, particularly with liquid biomarkers, where you have a negative readout, you follow the patient over time, and eventually it switches to a positive readout. That would be, if reliable, really enhance how we manage these patients on surveillance. This is the concept of continuous individualized risk index or dynamic risk profiling. And this is clearly coming. And a challenge in this area is to incorporate all the data we're going to get on individual patients from the molecular genetics, the biopsy, the germline data, the impact of diet, his fitness profile, the imaging and so on. And there's a major initiative going on in a number of centers to incorporate artificial intelligence, where you would collect all this data on tens of thousands of patients. You put in your individual patient's collective data and get an extremely accurate risk profiling. And this is really around the corner. Thank you very much for your attention. I hope you found this worthwhile.